Thank you so much, and I love all the history of palliative care and hospice that was mentioned too. So we'll go ahead and get started, and yeah, it's great to be back, kind of where you started, so thank you for the history there of me. So I just want to thank a lot of people that helped make this possible. We have nothing to close, but I want to thank Dr. Dunn, who's actually here. He's one of the palliative care physicians at Norton's Hospital for some of his slides. And Betty Rice and BJ, one of our residents, that really helped me with these screenshots. I'm not the most technically inclined, and so it was great to have some assistance. So today we're going to talk about the importance of advanced planning, advanced care planning. I just have to point out one thing. If you notice, there's no D on the end of that advance, because you do it in advance, like it's prior to when you actually need it. So it's just a little technical thing, but just when you say advanced care planning, don't put the D on it. And also just one technical thing, I noticed on some of the flyers that it said I was the program director for the Palliative Medicine Fellowship. I'm no longer the program director for the Palliative Medicine Fellowship. Mary Hubert is, so thank you, Mary, for taking that over. Okay, so the other goal is to talk about how to have a goals of care discussion, and we're going to go over the techniques, but if you really want to practice and learn more, today from 11:30 to 1, this is National Healthcare Decisions Day and week and month, and at Jewish Hospital in the fixed auditorium, which is behind the cafeteria there at Jewish by the chapel, we're going to have a session a little bit like this, but specifically let people practice having this advanced care, goals of care discussion. We're going to teach you how to complete a MOST form. So we'll go over that, and I'm going to tell you how to document the MOST form in the EHR, which is very complicated, so hopefully we'll make it much easier. So first, I want Justin Magnuson to speak. He is our MOST Coalition and Palliative Care Liaison for the Institute for Sustainable Health and Optimal Aging, and this is a picture of him and his grandmother, so he'll tell you a little bit about that. We always want to start with a case or a story, so this is our case and our story, so this is Justin.
Thank you, Dr. Furman. If you can tell by this picture, it's probably 1984 by my Michael Jackson t-shirt. I am 8 years old, and I'm with my grandmother. If you pan back, you would see that we're standing in front of Mount Rushmore, and my grandfather is taking the picture. So at this age, how many conversations around end-of-life discussions do you think my grandmother and I have had? Probably zero. Well, flash forward 17 years, and I am her only surviving kin. And guess how many end-of-life conversations we've had to that point?
Zero.
A half of one. It's a Friday afternoon. We have lunch. She is 80 years old. I am 25. On the way home from lunch, we're driving through this small town, and she says, by the way, I have a CD in that bank, and I have an insurance policy right there. And that's very nice, Grandma. We get to the four-way stop in Palmyra, Indiana, where she has lived independently since the 70s. And she says, by the way, I have a bank account there, and my funeral arrangements are there. Great, Grandma. We get home. She says, deed of the house is in this box. Checkbook is in this box. You can write checks, and I am do not resuscitate. So that's the half part of the conversation. That night, she drives herself to the hospital. Doesn't call us. Sunday, we get a call from her next door neighbor. She's in a small county hospital out in Harrison County. Basically, my grandma's been there for 2 days, and she was incoherent by the time we got there on Sunday evening. I walk in. So you have to picture, at 25, my hair was about down to here, and I had a big bushy beard. And I'm all of a sudden getting a crash course on how to navigate the healthcare system. And they keep looking to my father to make the decisions. And it took a long time to really get it across that it's like my dad was there to support me and help me make decisions, but when it came down to it, I was the one that was there every day making these decisions. And over the last 5 weeks of my grandmother's life, I got to make a lot of decisions. And I had support, but at the end of the day, I was the one that was having to go in and talk. I got to hear about my grandmother's sexual health history. I got lots of things that a 25-year-old typically doesn't have the opportunity to do. And over the course of that, I saw the shortcomings of our own planning. I saw the shortcomings of our own discussions around this. But then I also got a lot of just mixed messages about her prognosis and diagnosis. I got a lot of hesitancy of really talking about what was really going on. And a week before she died, she was refusing to eat, and she was talking to my great-grandfather, and it was never discussed that hospice and palliative care might be appropriate. So over the course of that experience, I got a really good, hard look at what it is to care for somebody at the end of life when you had no discussions. And it gave me a lot of passion to learn about how we can communicate this interpersonally, but then also between professionals and the patients and their families. We just need to do a better job at this as a culture. And I feel really blessed to work with Dr. Furman and the Institute and the MOST Coalition on getting out and doing these conversations. So I really, want to welcome Christian back up to talk about goals of care conversations and how this fits into documenting these really important conversations.
Thank you so much, Justin, because I think, we don't want to make it hard on the family. We want to make it easy on the family. We want to have this to be normalized. And so I think our job as physicians is to make it happen. So we want to make sure we improve the health and well-being of our patients. Patients need this information. We want improved system outcomes. If you do advanced care planning, before we started the palliative care fellowship and had started palliative care at the VA, and I remember in the doctor's parking lot when everybody was leaving, at 4 o'clock. No, not just when we were leaving the VA, and one of the faculty that had been a renal faculty attending for a long time, and he came up to me and he was like, "Thank you so much for starting palliative care," because he said, "I knew I wasn't doing the right thing. That I shouldn't be dialyzing these people that were in stage dementia, dying people. But I didn't know what else to do, and now I could actually refer them to palliative care." So we want these system outcomes to improve, and I think we have to have this process in place so we can do the right thing. We know what the right thing to do is. It's also cost effective. It addresses the triple aim. The triple aim is better patient care, better care for the patient, better care for the community, and at lower cost. And so that's what we're trying to do. So this is some good research. This was Dr. Tino and her colleagues found that in the last month of life, 50% of older adults go to the emergency room, and 75% are hospitalized, and 66% die in the hospital. So really, last month of life, do you really want to be in the hospital? Not necessarily if you really talk to people. 40% of Medicare patients receive ICU care in the last month of life. The problem is if they knew it was the last month of life, maybe they wouldn't. But I think no one really knows it's the last month of life. You had a crystal ball. But there are a lot of ways we could know it's the last month of life if we were paying attention. And at the end of life, in the last 3 days of life, only 25% receive hospice care when they only have 3 days to live. We want hospice to be involved 6 months beforehand, not 3 days beforehand. And 80% of people, if you ask them, want to die at home. And just think about yourself. Like if you're thinking about how I'm going to die, like no one wants to think about it. But people have a birth plan, so it's okay to have a death plan. It's okay to think about, like, how do I want to die? Do you want to die hooked up in the ICU? Like you personally, most people think I just want to die at home. And Barbara Bush died yesterday, maybe the day before, and she died at home in her house in Houston. So if you think about it, most people want to die at home. But actually, more than 50% of people die in the hospitals in the United States. So this is what we're trying to address, and this is why advanced care planning is important. So these are some good visuals, and these are slides that Dr. Dunn came up with. But on the left, this is dying well is living well. So, we want you to live the best life you can. It's not really about dying, it's about living. And hospice has those great commercials about people, fishing and as they're dying. And, you can still fish when you're dying. You can still hike when you're dying. You can still enjoy your family when you're dying. This bottom one, everybody's like jumping around, around a dying patient. So you want to be around people. But what happens a lot of times is this right-hand side. People die by themselves in the ICU hooked up to machines. Maybe their nurse is beside them, but, they're restrained. Who wants to die restrained, So we're trying to get away from this right-hand side. And the way to do it is to plan ahead and have an advanced care plan. And you think, who should you be having these conversations with? Really everybody. Everybody over the age of 18. But even in pediatrics, some 16-year-olds can have these conversations, or it depends. It's not really age. It's really developmentally how are people able to have these conversations. But for sure, prior to diagnosis, like when it's calm and peaceful in the doctor's office as an outpatient, children born with debilitating or life-limiting illnesses, the doctors and the family should be having these conversations. Anyone before you go to the OR should have this conversation. Crazy things can happen. You want to make sure you know what the wishes are. I wonder if Justin's grandmother had an inkling of what was going on and she was pointing out things, So people kind of have a sense, and so they want to tell you these things, and they started talking to you about these things. You need to listen. Anyone with a chronic disease, you never know when that chronic disease is going to just turn south and go bad. So there's tons of examples. Everybody should have an advanced care planning conversation. And so this is a good slide to kind of talk about when and how palliative care can be involved in this. Really, palliative care should be involved at the time of diagnosis. Right here, this is diagnosis. A little bit right at the time of diagnosis should be palliative care. Advanced care planning. Do you have a living will? Who's your healthcare surrogate? If something goes bad, who do I call? But most of it is up here where you're doing the medical management of the chronic illness. But as time goes on, this is time, it does become more that you should be doing a lot more palliative care. You still you want to manage the illness. Sometimes the curative care is the palliative care. In congestive heart failure, we don't stop their diuretics. We try to keep them so they're not short of breath. That is palliative care. We don't want people to be short of breath. In the last 12 months, there is usually a goals of care shift. If people are thinking and planning and starting to figure out what the prognosis is, and there's lots of research to know how to prognosticate. And then when people die, they die here, so the last 6 months before they die is really when you can get hospice involved. That's just because that's what the House and Senate voted on one time to say this is what the hospice Medicare benefit should be at 6 months. There's no magic to 6 months, it's just what financially the House and the Senate thought would work from actuarial data. And then after someone dies, there's a bereavement period, and you should follow them. Hospice officially follows people for 13 months after someone dies, because 13 months gets you through all those milestones. That 1 year at death is so hard, and so that's why they pick 13 months. So you can see palliative care and curative care can coexist. Advanced care planning can exist through all this. Okay, so to do advanced care planning and figure all this out, you have to have this conversation. And this is the hard conversation. But just know if you have this conversation, it saves time, it saves money, it relieves everybody, it's good. So we're going to talk about when goals of care need to be established, who needs to participate, talk about the details of how to have this discussion. We're going to talk about specifically the DNR discussion. And I would propose, and I'm not the first one, I didn't come up with this, instead of saying DNR, do not resuscitate. It's something negative, like they're not going to get something. Some people in our healthcare system have been denied medical care their whole life, and by God, when they die, they're not going to be denied medical care. So if you say do not do something, it's like don't do something. It's bad. So it's to be more positive, it's allow natural death. It's a normal thing. It's okay to die. And a lot of hospital systems and healthcare systems are going to A&D, allow natural death. It's a positive. You're not going to deny anybody anything. And a lot of this is from Dr. Wiseman, and this is what Barb was talking about. He came and gave a presentation, and it's still appropriate. So, you can do this any way you want and muddle through it, and it'll go bad probably. So I'd encourage you to use the technique and kind of do it the same way all the time. So, when you're in the hospital, you should have this conversation. I give this example all the time. When I was a new faculty, maybe my first or second year in, one of my partners was Dr. Pat Murphy. I don't know if he knows Dr. Murphy. He's still working, mostly retired, but so, he was in the hospital, I was in the outpatient setting, and I had a new patient. I'd done the whole H&P, I knew when her mammogram was, I knew when her last mammogram was, I knew if she smoked, I knew all the details. And he was taking care of this patient in the hospital. He's like, Christian, so what's her advanced directive? Does she want to be a full code or DNR or what? I'm like, I never asked that question. I never remembered that was. No, he's like, she has chronic, serious COPD. He's like, why didn't you ask her about her advanced directives? And I'm like, sorry. So, don't wait till they're in the hospital, but for sure when you're doing your admission H&P in the hospital, you ask them all kinds of other questions. Ask them what their advanced directives are. Maybe they have it in a lockbox somewhere that they told their grandson, 5 years ago. So you need to ask these questions. When the patient has a chronic exacerbation, that's a good time. When they're admitted to a nursing home, an assisted living, a personal care home. And a lot of times they're admitted from those places from here. They're in the hospital, they would go to those places. So it'd be better, you see these patients every day. You should be having the conversation while they're here. Because I tell you, when they go to the nursing home, the doctor only comes every 60 days. And some people are better at it than others. And sometimes it gets done and sometimes it doesn't get done. And you want to do this as healthy outpatients as part of routine advanced, part of your routine H&P. And we'll talk about this later. You can actually get paid for it now. So why not do it, right? So this is what I was talking about. Who needs to participate? For sure, the patient. I think sometimes we forget the patient. Even on the ventilator, a patient can shake their head yes and no. They can write. They can communicate. So the patient needs to be part of it. Because even a patient with dementia, I have a lot of patients with dementia. They might not know where they are. They might not know the exact day, but they can know they don't want a feeding tube. They know they don't want to go to the hospital again. They're spitting out their food. They don't even want to eat, right? So get a sense from the patient. Have the patient be a part of it. If they are not decisional, then look and find, do they have an advance directive? They might have actually already figured this out and told their grandson or told somebody. So ask around, figure out if they have an advance directive, and read the advance directive and do what the advance directive says. I had a patient show up in the nursing home one time and had a feeding tube. And then we pretty much get the advance directives when they're in the nursing home. We're pretty good about that. So I'm looking at the advance directive, and there's that box check that says he does not want a feeding tube. If you read the top of the advance directive, it says, if I have a terminal illness, permanently unconscious, or I forgot the third name, this is not what my wishes were. This patient had end-stage dementia. He did have a terminal illness. There's no cure for dementia. So people die of dementia. So this advance directive was applicable, and he had a feeding tube, and he had checked a box he did not want a feeding tube. I'm like, how does this guy have a feeding tube? So I asked the family, I was nice about it. I was like, how dare you? Like, what did you do? They're like, just trying to figure out how to get the feeding tube. Oh, well, in the hospital, he wasn't eating, so they said he needed to be fed, or he needed a tube, or he needed a peg. And the language, they didn't realize that in the advance directive it says tube, artificial nutrition, hydration, or feeding. They didn't connect the dots that this peg was his artificial feeding. Like, no one explained that that's what this meant, So, I don't remember exactly what happened. I think what happened is we just stopped using the peg. He never wanted to be kept alive artificially with a feeding tube. So you don't have to just yank it out. You can take it out, but we left it for a while. I have taken them out in people in the nursing home because they start draining, they get infected, they're pulling on them. So just know you should read the advance directive, interpret it to the family, make them understand what it says. Because maybe they never told their family they even did one. But if there is no advance directive, then sometimes they did appoint someone to be a healthcare surrogate. So ask around, figure out who the healthcare surrogate is, ask the healthcare surrogate. If there's none of that, if there's a guardian, talk to the guardian. But if there's none of that, then Kentucky law says next of kin is spouse, it makes the decisions, then the adult children, and is the majority of the adult children over the age of 18. You don't have to go to the ends of the earth to find people that don't want to be found, but the ones that are readily available. You do have to make some effort, but some people you just are never going to find all 12 kids. Parents then make the decision, then other relatives. And that's where it stops. Some states actually say people that would know the patient well, like the landlord that they talk to every day, and they said what their wishes were. But Kentucky doesn't go to landlords. Kentucky stops at relatives, cousins, whatever. Some facilities allow physicians to make decisions if you have two physicians for this non-beneficial treatment policy, but each facility is a little different. I think our hospital has that policy where two physicians, if there's a whole policy about the non-beneficial policy. The physician of record needs to be a part of this. I saw an order one time in the hospital that said, social worker to discuss goals of care with the patient. The social worker can fill out the paperwork and kind of get it notarized and do all this stuff, but the social worker can't tell a patient they're dying. They can't tell prognosis, so don't shirk your responsibility as a physician. You should be having this conversation. You should be telling the prognosis. And then, definitely the other people that need to be around that table when you're having the discussion is family, friends, social workers, nurses, chaplains. Have your team there. If you have 12 family members, I would encourage you to have more than one person on the other side because you're going to be overwhelmed. You need to have some other people with you when you're having this conversation, especially if it's going to be tricky. So this is what I was going to say. This is the technique to how to do it. So don't just muddle through it. Actually use the technique. Try to do it in order. Practice it. And the more you practice it, the easier it gets. So before you're having this conversation, decide in your own mind, what's reasonable? What's going on? What's the prognosis? What's appropriate? What's not appropriate? Find a quiet, private place to meet. I give this example. I remember when I was a resident at the VA, I think I was maybe an intern, and we had this patient that needed a goals of care conversation, and my upper level resident, I thought was God. I thought did a great job having this conversation. He actually talked to the family. It was one of the few residents that actually talked to the family. I thought it was beautiful. Now looking back on it, we stood in the hallway outside the patient's room and had this conversation. I was like, oh my God, we stood in the hallway and had this really important conversation. So I would encourage you not to stand in the hallway outside the patient's room and have this conversation. It's really hard sometimes to find a quiet place to meet. A lot of times we're kicking the nurses out of their break rooms, which is awful. But now that hospitals are being renovated, a lot of times they are putting quiet areas for meetings. So find that quiet area. The first question you always ask is what the patient knows. So you always say to the family and the patient, tell me what you know about your illness. What do the surgeons say? What do the oncologists say? What's your understanding of the situation? And they'll be like, you're the doctor, you tell me. It's like, no, you're the patient, you tell me. It's like, I've had that go back and forth. It's like, no, I do know everything. I have read the chart. I know what's going on. But I just want to hear in your own words, like, what is your understanding? And that skips like half the conversation, because sometimes they'll be like, oh, I'm dying. I know I've been dying. I've told my grandson where my stuff is, and I've got my funeral arranged, and I'm ready to go. So then that kind of leads you down one path. But some of them, they're like, oh, I'm fine. I just have some diabetes. And you're thinking, what about your colon cancer? What about all this? But they're like acting like they don't know about it. So then it just kind of gets you on the same page. And also, if you let the patient start talking first, then they will keep talking, and it'll be a two-way conversation. If you start talking first, you will talk the whole time, and they will not talk. It'll be a lecture. And you want to hear how they talk. What words they use. They use high medical health literacy words, then you can use high-level words. If they're very simple language, you need to use very simple language. So that's the first question. And I do this a lot, and I still miss that. I still just jump right in and tell them what I think. It's like, no. Ask them what they think. What do they know? Then you kind of go over everything with them, talk about prognosis, talk about the medical condition, fill in the blanks, have questions. And then this is how I kind of do it. It's based on Wiseman. It's based on a lot of combination of things. But there's 4 ways that you can treat people in medicine. One way you can treat people is to cure. I mean, I say this and I hold my finger like, we can do this, cure. Rarely do we cure a lot of these diseases, but sometimes we can. So maybe the goal is cure, eliminate disease. But sometimes we can't. We can't cure dementia. But they fall and break their hip, we do rehab. So the second goal is rehab. You get them up, you get them moving, you restore the function. But even sometimes people can't do rehab. They're so sick. They're dying. I mean, I've had people in the nursing home that come there for skilled care rehab. They are dying. And they're making these poor people get up and walk. I'm like, just leave them in bed. I mean, they're dying. But no, we have to skill them for rehab, Well, nowadays we figure out we can skill people for other things. We can skill them for end-of-life care, thank goodness. But some people just can't do rehab. They're too weak, they're too tired, or they're too demented. They can't follow directions. They can't remember what they were taught yesterday. They're fighting you when you touch them. But you can try rehab. Sometimes you have to try it just to see if is it going to work or not. And after rehab, the third way we treat people is life-prolonging palliative care, where we do stuff to keep people alive. We put them on ventilators, we do dialysis, we do blood transfusions, we do antibiotics, we do chemo. It's fine, it's good, it's fine, whatever they want. And that's usually if someone is not ready to die. They haven't got their affairs in order. It's a young mom who's going to take care of my kids when I die. I've got a wedding next week. I've got things to do. I've got unfinished business. So you do stuff. You give them a blood transfusion, get them to the wedding, get them to the next event. But I've had patients that say, I've graduated, all my kids are married, I've lived a good life, I'm 80 years old, I'm ready to go, I don't want to suffer anymore. So it's okay. It's you kind of have to have that conversation, because sometimes it's hard for them to figure out the difference between number 3 and number 4. And I just ask them, is there unfinished business? Is there things that you need to attend to? If so, we should do life prolonging. If not, then the 4th way we treat people is comfort-focused palliative care, where you don't need to prolong their life, you don't need to shorten their life, you just kind of let nature take its course. And you very aggressively treat their pain and symptoms. And people can go back and forth through this, they can change their mind, but it's good to just kind of have a sense about what we're trying to do. And then once they tell you what the goal is, you tell them what that means. You don't ask them, do you want antibiotics? Do you want tube feeds? Do you want like a smorgasbord? You just pick what you want. It's like, no, you're the doctor. You find out what their goals are, their values are, how they want to live their life, what their wedding plans are, what their life things are going on. And then once you figure out that with them, what their goals are, then you can kind of fill in the blanks. So, after you kind of talk about the goals, there's lots of questions, develop a plan. I would encourage you not to say anything about we're going to withdraw care. Who wants to withdraw care? I mean, we don't withdraw care. We always care for patients. The question is, do you want to say positive things, what we are going to do? So do you want curative care or comfort care? We're still going to treat you either way. All those treatments are valuable and valid. So document the discussion. I've had this happen. I had a resident medical school student have an hour-long conversation. I'm like, go document it. And it's like 2 sentences. I'm like, we just spent an hour in there. You have like 2 sentences, So you want to say who was there, what was present. And then, but what happens, they didn't document anything because they're still a full code or nothing's changed. I'm like, even though nothing's changed, you plant a seed, you have a discussion, then the next doctor coming around behind you can see what happened and follow up on that discussion. So document who was there, and I would encourage you to say the names of the people that were there. Poor Dr. Murphy, I use him as an example all the time, but I remember I read his discharge summary and it says, discuss with the family, goals of care or comfort. So then I'm attending Nick's and his patients in the hospital. I'm like, I walk into the family. Oh, I know goals or comfort. We're going to do this. They're like, who said goals or comfort? My sister said that. I think this. Well, come to find out there's like 12 kids and like 6 of them said the goals were comfort, but the other 6 didn't say that, So like, who actually was there? What are their names? Not the daughter. Well, there's 5 daughters, So, and you have to talk with the rest of the team. This is where I made a big mistake too. I've made all the mistakes. But, I remember I was at the nursing home. And this is when I had little kids, and the daycare closes at 6. You got to get your kids by 6, right? You pay $5 a minute afterwards or whatever. So I had the whole conversation, took an hour, which is fine. These conversations usually take about an hour. If you're good, maybe you can do a little less, but don't go over an hour because you're just rehashing the same thing over and over, and no one's deciding anything. But then I didn't have a lot of time to document. So I did document, but I didn't have a lot of time to talk with the rest of the team. So I ran out of the nursing home. Well, then I get called to the administrator's office. We have to have a big, I got in trouble, because basically the nurses were not on the same page. And they're like, Dr. Furman's trying to kill off people. What is she doing? Going and writing these do not hospitalize, DNR, comfort measures only, stop the antibiotics. This patient's fine. Fine. So in the nursing home, this is like the best patient at the nursing home, but don't forget, like, we're in a nursing home. They're not doing too good if they're in a nursing home, But I think people lose perspective, and on the outside, looking at this patient, they look fine. But like on the inside, they got cancer, they got dementia, all this stuff, but the nurses aren't like reading the medical record from front to back. So you have to talk with your team because the nurses are not going to write for the morphine. They're not going to give the morphine if they don't understand what's going on. So if you can't do it, call back on the phone and make sure everybody's on the same page. And what I figured out from that experience is I don't have those conversations without the nurse with me. I just bring the nurse right in with me. We do it together, or the chaplain or somebody from the system that you're working in that could kind of be there and validate everything. So this is where we want to start talking about this MOST form. I want to explain this. There's 2 types of advanced care planning. One is the traditional, everybody knows about. Kentucky passed a law that we have advanced directives. Advanced directives, there's a big thing called advanced directives. There's 2 parts of it, your living will and your healthcare surrogate. We've been doing that since forever, since the 80s, I think is when that law was passed. But now we have a new thing called a MOST form. And the MOST form is this, and if you don't have it, let me know. We'll pass some more out. But these are actionable medical orders, which are direct. This is an order set. The living will is a document that we hope that someone looks at and will read. But this is an actionable order set. In other places, it's based on this POST paradigm. Other places, it's called POST, Physician's Orders for Sustainable Treatment, or MOST or MOST. In Kentucky, it's called MOST, Medical Orders for Scope of Treatment. And so we're going to go over all the details of it. But the purpose of MOST is to provide a mechanism to communicate the patient's preferences for end-of-life treatment across treatment settings. So you take this piece of paper wherever you go, to the emergency room, to the nursing home, to the dialysis center, to the chemo infusion center, like everybody knows where it is. You put it above your bed, on the refrigerator, and this is an order set, and these orders should be followed. So what's happened to me in the nursing home, I'd have this hour-long conversation. I'd document the whole thing on a progress note. I'd write orders, DNR, do not hospitalize. And then nothing would happen for like 6 months, right? Well, then by that time, the notes are thinned. They're in medical records. The medical records close at 5. I'm there at 6. This person's crashing. And I'm thinking, I think I had this conversation like 6 months ago, but I can't really remember the details of what they decided. I mean, I wrote a DNR. I wrote do not hospitalize, but did they want antibiotics or not? Did they want to go to the hospital? I can't remember. Did they change their mind? Who decided all this? And I can't find the documentation. It's been thinned, and it's not, there's no scanning, there's no electronic medical record. It's thinned, it's in medical records, and medical records is locked. So it shows up in the chart. That's why it's a bright pink. It's in the plastic part, and you can find it. So we're going to go over where you can find it in electronic medical record. So I just want to go over it. If you can pull this out, I'll explain it to you. The section A is pretty much like it's pretty much like what you've seen on Advanced Directive. Is it attempt resuscitation or do not attempt resuscitation or allow natural death? Section B is the new section. This is not on a living will. Do you want full scope of treatment, which includes intensive care, full treatment, life support, transfer to the hospital? Or do you want limited additional interventions, which is transfer to the hospital if indicated, but avoid intensive care, and that's basic medical treatments? Or do you want comfort measures, which is do not transfer to the hospital and keep you comfortable, clean, warm, dry, clean. And you can write other instructions there. And then section C is antibiotics or not. Do you want antibiotics or not? Or you could say I want antibiotics for a trial. That's not in a living will. Section D is in a living will. The left-hand side is IV fluids. The right-hand side is feeding tubes. And then section E is who did you talk to about it? And this part is patient has an advanced medical directive such as a living will or healthcare power of attorney. I certify this form is in accordance with the decisions in the current advanced directive. I had to testify in Kentucky in the state legislature, the House and the Senate committees about this. And I tell you, these House and Senate committee members, they were really hung up on this because people have an advanced directive already. And is this going to supersede it or not or what? Because advanced directive, you do yourself personally, and that's the only person that can do it. So that's why you can't wait till someone's so demented they can't do their own advanced directive. If it gets too far gone and they can't make their own decision, there is no advanced directive to be done. But this MOSE form, anybody can do it. A healthcare surrogate, the patient can do it, but a healthcare surrogate can do it. So the legislature didn't want a healthcare surrogate coming around after the patient already decided one thing and changing it to like kill dad off and get his money or something. So that's not what we're going to do, but that's what they were worried about. So you have to certify. So if this does not match what the living will is, I would recommend you just don't do one of these. Or call the ethics committee, call a palliative care consult, figure it out. It gets complicated. But, and then a physician has to sign this. We titled it medical orders for scope of treatment because the thought was like physician assistants or nurse practitioners could sign it, but the legislature is going to have none of that. Only a doctor can sign this. So in rural areas, sometimes there is no doctor to be found for like 100-mile radius or something. It's all nurse practitioners, but they're going to have to get this to a doctor to sign it to make it legit and make it legal. This is a legal document. And I'll explain the history of it a little bit, but I just want to tell you a little bit more about the difference. And also on the back, if you read it, it tells you you have to write a progress note when this was done. Sarah, our palliative medicine fellow, and I were working on this. And you just had to practice this to remember all the rules. And we kind of wrote a progress note, but I was like, what do they want in this progress note? So I read it a little bit more clearly. They want a progress note to explain, like, how did this come to be? Like, how do they decide these things? It's not about if they have CHF or COPD or anything. It's like, how did this come to be? So you don't want to just go around writing DNR on everybody without, like, a progress note to go with it to explain it. So you can see the difference here in advanced directive. It's for all adults. The MOSE form, they really recommend you do this if someone has less than a year to live. Now, anybody can do it any time, but just know when you do this form and fill it out, this is an order set. It takes effect immediately today. Like if you show up in the ER, this is what they're going to do. So it's people with more serious illness. And then the advanced directive is for the future, if I become permanently conscious, like in the future. But the MOSE is right now. Like I said, who does it? I already talked about that. An advanced directive, it says any setting, like a lawyer, a lot of lawyers do advanced directives. My husband's a lawyer. I love lawyers, but really, this is not the lawyer's job. Like, we should be doing this, Because the lawyer puts in a lockbox with all the other important papers, and no one has access to it. We want this to be like on the refrigerator. So really, they say a medical setting, but I would say the MOSE form can be still done in any setting, but a doctor has to sign it. That's the big deal. So whoever fills it out, that's great, but take it to the doctor to sign it to make it legal. And then the resulting product is a surrogate appointment and statement of preferences, and the MOSE is medical orders based on shared decision-making. We talked about who can do this. The portability of the advanced directive is hard. It's the patient, the family that's responsible for going to get it out of the lockbox or whatever. But the MOSE form, it's our responsibility. Like when we fill this out in the hospital, we make sure this goes with them to the nursing home. The nursing home makes sure this goes with them to the dialysis, to make sure it goes with them to the oncology doctor's office. So it's a healthcare responsibility. And then you have to review it. So, and they really recommend you review it every year. The kind of thought is only for people that have less than a year to live, so they probably won't be alive in a year, but they might be. If they are, you have to update this every year. And you update it whenever there's a change in condition. So the big question is, like, how do you know someone has less than a year to live? Like, how do you know when they get this form filled out? It's a surprise question. Would you be surprised if this patient dies in the next year? maybe, like, I could see that happening. Well, then fill out the form. I mean, they could live for another 5 years. Who knows? You never know. But if you wouldn't be surprised if they die in the next year, then you should do it. And I hate to say this, but I use this as an example a lot at the VA. I haven't been there in a while, but it used to be like, I think almost half the people in the VA, I wouldn't be surprised. So, go ahead and just fill out the form, and the VA has these. I think the VA calls them VOST, veterans. Did you ever see a MOST form at the VA? They have them. I know they're part of our MOST coalition. I'm not sure if, I know you have to, each state has a different form. But a lot of these veterans, it's travel across state lines, and same thing when you're traveling, like here, Kentucky, Indiana, where people go back and forth. Indiana has one of these. You need to fill out Indiana's both. You need to have both of them if you have a patient that's going back and forth. So the benefits of MOST, it establishes the patient's decisions, and the patient is able to have their decisions honored. It improves the HCAP ratings, improves quality, increases staff comfort with these difficult conversations, like the renal attendant that caught me in the doctor's parking lot. Like, he didn't know what to do. He knew he wasn't doing exactly what he should be doing, but he didn't know what else to do. Well, just read this form and check the boxes. It's so nice, because when I was having these conversations in the nursing home, I had done research, and I knew you didn't have to give antibiotics to people that were dying. They used to call pneumonia the old man's friend. Like, it was okay to die of pneumonia. You give people morphine, you give them oxygen, you give them breathing treatments. You're still treating the pnumonia, but you don't have to treat it for cure. You're treating it for comfort. But people look at me like I'm crazy that you don't have to give antibiotics. I'm like, yeah, they don't swallow the pill. You have to tie them down to give them the IV. Like, it's okay not to give antibiotics. And they thought I was just making it up. But I was like, now it's in black, or pink and black. It's on a piece of paper, like it's for real, So it's nice to have it. It helps the staff. It helps you all. It helps everybody. It does decrease length of stay. It decreases hospital readmissions. And now we can bill for it. Advanced care planning codes. And I'm going to go over that. Just in general, most in Kentucky, it's like everything else. Kentucky's a little bit behind the times. Like, Oregon's had this for years and years and years. But Kentucky Association of Hospice and Palliative Care spearheaded this as a pilot project in 2010 at the nursing homes. And it took us 3 years to pass this legislation, and Governor Beshear signed it into legislation in March of 2015. But it's been housed by the Kentucky Board of Medical Licensure, like they're in charge of this form. And it took them about a year to kind of come up with the rules around it, and they put it on their website in November 2015. And so really it's only been since 2015, the end of 2015, that this has happened. So in 2017, in January, we started the statewide MOST coalition to kind of get this out there, get people to understand it. And so now we're using it in nursing homes. Norton's using it, Baptist, St. E's, Owensboro, Nazareth. A lot of people are using this form. U of L and ULP are not really using this form. So we're trying to get everybody to start using this. So you can see our coalition. This is if you go to this website at the top here, you will actually get to our website, but we're trying to make it a little bit easier, and we still have to finalize that, and I'm sorry it's taken a little longer than we wanted. But the Kentucky MOST Coalition is a statewide stakeholder group. That's the actual law there that passed this as law. So it's nice, because when I first started at a nursing home, I was using advanced directives, just regular living wills. I was writing orders, do not hospitalize, no antibiotics, all the stuff. And I wanted to start using this. Oregon was using it. Let's just use it at a nursing home. They had their lawyer write me like a 20-page letter where I could not use this form because I was supposed to be using the advanced directives, which was Kentucky law, and this was not Kentucky law. So now I want to go find that lawyer and tell him it's Kentucky law now. We can use this form. It's legit. It's okay. So the MOST Coalition, I said that. We have over 100 members in about 15 counties. The goal is to have every county represented. We've gone to Hazard. We've gone to St. Elizabeth's. We've gone to Owensboro. And we have nurses, physicians. We want to add chaplains and patients. So if you all would like to be part of the MOST Coalition, we have every other month calls. You can call in, or you can come face to face. And we have a sign-up sheet that's going around, and also back on the table you can sign up. So you can see across the country. This is really exciting because this was January 2018. Just a few years ago, there was a lot of states that had nothing. But some of the mature programs, it used to be Oregon. Now Oregon is now separated from the National Post Organization due to operational differences. They're kind of doing their own thing. But still, they're a very mature program. Oregon started all this, but also California and West Virginia. And I thought, if West Virginia can do this and become a mature program, Kentucky can do this and become a mature program. But we are currently a developing program. So we're getting there. We're getting there. So we want to have a system champion to make this successful. We want staff who understand it and have comfort discussing it. Because really a nurse can discuss this, a social worker, anybody can discuss it, chaplains. We want to have policies and procedures. So we've been meeting with ULP. We've been meeting with U of L Hospital. We now do have policies and procedures. We just have to get the IT part to make it happen. We do have support from EMS. EMS has a video on their EMS website that I'll show you at the end that they've told other EMS people, look for this above the bed and on the refrigerator. This does replace the DNR for EMS. I mean, you can still use the DNR for EMS. You can use both. But this they know, they recognize. We want to have a monitoring process, a quality improvement process. We have to have physician involvement because physicians have to sign it, you know. So if someone asks you to sign this, please sign it. At least have a conversation. You have to do a progress note to go with it. We have to have workflow. And we're meeting with ULP again on Tuesday, and ULP and U of L are now a health system, so we can have the same process in both places. And I'm not going to go through this whole workflow, but this is if you have a life expectancy of greater than 1 year, and this is if you have a life expectancy of less than 1 year. And you can see right here, part of the workflow is to complete the MOST form. So this does improve quality measures. So the big thing about the advanced directives is to be able to document it, store it, and can retrieve it. And this is the big problem. I'm going to show you this. So in all scripts, there is a ribbon where you have the patient's name, date of birth. They just added this over here. They changed it a little bit. And I don't know if you've noticed, probably you don't see it much because you don't put it in there. But if you put it in there, it will say Directives Living Will. And I'll show you how to put it in there. You click on the I button. The I button tells the patient's phone number, address, next of kin. Click on that I button, the information button. And this will open the patient profile dialog window. So I'll show you. Push on that I button. You get this screen. You get the picture. It's not Wonder Woman, but it is a picture of a person. And right here, sometimes you have to scroll up here. Make sure it's at the top because this is at the top. And then you click right here where it says directives. And you can click, do they have an advanced directive, yes or no? And if someone actually is a do not resuscitate, like they fill this out no matter what, they're a DNR, go ahead and click it. They're a DNR. You can write an order, a DNR order in the outpatient medical record. If they have a living will, click it. That's all I click. So that's the things that you click. But sometimes I want a little bit more detail because whatever you click there is going to show up in the top right of the banner up there. But sometimes I want to know a little bit more. So I'll do an add alert, which when you're doing an add alert, if you, an add alert, like right here has like a little red thing that you'll sometimes see like allergies listed there or when their last PQRS was or whatever you want to put in there, dialysis patient, whatever. So if you do an add alert, it'll show up there and I'll say, if reversible, full code, if irreversible, DNR. Some people have told me that, like, if I can save me, save me. If I can't, let me go. Well, if it's irreversible, let me go. So I'll put that up there. And I'll say C41818 note. Then you write a progress note to go with it. Then the person can find the note and read the whole note and figure out what's going on. So then you always save and close it so it's saved. And then the add alert, I told you about that. And then to actually find these advanced directives, so they get scanned in the EHR, when you're on the chart viewer screen and you see all your progress notes and stuff, I don't use this button. I don't have this. I looked at my screen. I don't have this button. But I have this button. It's plus minus. It collapses and it expands the chart viewer. And if you collapse it, it'll give you these categories. And one of the categories is administrative. It's always at the very, 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 very bottom. If you're scrolling through all of them, it's at the very bottom. And under administrative, it has advanced directives. Now, you might not see it because your patients don't have advanced directives in the chart, but they have advanced directives in the chart that are scanned. It will say living will, power of attorney, and it will be in there. And their advanced directive, their MOST form, everything will be scanned right there. Cerner, I do work in Cerner, but I don't do it but once a month. And so I'm not as good. So BG helped me with this. But if you want to add a document in there about advanced directives, you go to documentation, go to add, and then dynamic documentation. And then you can choose all, and it says acute dysphagia, but you can type that in there and say like MOST form, and then you can write a progress note to kind of go with it. That way you could find it under advanced directives because it'll say advanced directive living will. You can pick that category, and you can free text it. So the thought is that we could do like a MOST form template and have it in there as part of the free text documents, like you have your H&Ps and things. But this is so crazy. To find an advanced directive scanned in a Cerner, it's like about 20 steps. So, that's the whole problem is that it's too complicated. We want one click. One click is a better system. So we're going to be working with IT to kind of fix that. If you have any ideas, please let me know. The big thing is to educate everybody. Yes, I know, Tom. I'm sorry. I was looking at you. I saw you in the audience. So, everybody, not just physicians, the hospital, everybody in the hospital, everybody in the outpatient setting, all the nursing homes need to be educated. It's funny, we were doing this as part of a grant, and I was doing this with one of our family medicine residents who's now, I don't know, she wasn't here. She went to medical school here, residency away. She was in Glasgow. And I was like, okay, Meg, you need to meet with, she was doing this at her nursing home. I'm like, you got to meet with all the hospitals, make sure they have this, because, when you send people from the nursing home to the hospital, the emergency room needs to know about this form. She's like, Christian, I got it covered. My husband's the ER doctor. There's one hospital, there's one nursing home in Glasgow. She's married to him. She's like, I'll talk to him tonight. He'll recognize this form. I'm like, okay, that's done. But in Louisville, there's a million hospitals, a million nursing homes. We had to talk to everybody, but it does make it easier being in a smaller town. So you have to have champions. I want to just tell you about these codes because, why do all this work and not get paid, Like I said, my husband's an attorney. They get paid for every 8 hours. 8 minutes. They bill 8-minute intervals. Every letter they write, every phone call, they bill for it. So we can bill for this now. So 99497 is the first 30 minutes, which is actually 16 to 45 minutes. So if you spend 20 minutes, if you spend 16 minutes, you should bill for it. And then if you spend more time, if you spend an hour, you can add on both codes. It has to be face-to-face with the patient, but not just the patient. In the past, it was only the patient. Now you can bill if you're just talking to the daughter or a family member or a surrogate. And not just the doctors can bill, the nurse practitioners can bill, and licensed clinical social workers. Anybody that can bill Medicare, this is a Medicare code, non-physician practitioner. I just want to show this article, which kind of talking at the beginning, what the research is on where people die and how they die. But Oregon, like I said, has been doing this for a long time. They've had education, they've had toolkits, they've hosted conferences, they coordinated stuff. They have a statewide registry. There's a great video if you go to the Pulse website where EMS calls a statewide registry and says, hey, I'm seeing this patient, call 911. They call the state registry. They tell them what their MOST form says, and then they know what to do. They don't take them to the hospital because they were do not hospitalize. Lots of stuff. There was no industry funding, but a lot of support. And in Oregon versus the United States, died at home. Oregon, 66% of people died at home. Just like Barbara Bush, she died at home. In the United States, 39% of people died at home. Don't forget, the research showed that 80% of people want to die at home. So Oregon's getting close, but we're not as close. Maybe we should do research on Kentucky. I don't think anybody's done that. In the ICU, Oregon, only 18% were in the ICU in the last 30 days. In the U.S., 28% were in the ICU. Home the last 30 days, Oregon, 73% were at home. In the U.S., 54%. And Oregon showed that tube feeds did not extend life, and there's low rates of tube feeding in Oregon versus the United States, the rest of the United States. So it works. So my whole point, if we do all this, it actually shows outcomes that will work. And just know that the form is not the main thing. The goal is to have this conversation. And MOST doesn't replace an advanced directive because the advanced directive is for the future. The MOST is for today, so you need both. And please bill for it because, Medicare has this code. They want people to bill for it. If nobody uses the code, they're just going to let the code go away and we won't be able to bill for it. So you kind of use it or lose it. And you have to have a whole broad-based approach. So please be part of our approach. This is lots of resource, Pulse website, all this Pulse stuff. www.pulse.org is like the big coalition, has a lot of good information. Here's our MOST coalition. When it gets up and running, it'll be KY MOST. And then this is the KRS, the actual law, the Kentucky Board of Medical Licensure website has it on there. And this EMS video is great. It shows that EMS totally gets the MOST form. They've already got a video out about it. The Conversation Project's good. There's lots of things. And this is our contact and Justin's contact. You can sign the MOST Coalition website, the sign-up sheet, and there's lots of good references. So I know we're running a little bit late, but I could take maybe a question or two. Yeah?
Thank you very much for a wonderful presentation. I work in a non-academic setting. So my first, I have two questions if you don't mind. The first question is, how you open a dialogue or your specialist like end-stage myopathy or end-stage COPD or oncology, how do you open a dialogue? How do you exchange information for prognosis part with the patient, their family, and the progress? And the second question I'm going to add to it is end of life discussion. How we can progress this, how the Oregon has done a marvelous job and how to make the patient, how we can improve in Pentakiana.
Yes. So how do you have this conversation? How do you start the conversation? Sometimes you don't want to just blindside someone, like today's the day. So a lot of times if you know, in your mind, you kind of have a sense, this person's been back and forth to the hospital every month, they're not getting better, or they just have like ejection fraction of 10% or whatever criteria. Everybody knows their organ. You kind of have a lot of research about when people are going to die. If you kind of think this person, the surprise question, you wouldn't be surprised if this person dies in the next year, then you think in my mind, okay, I need to have this conversation, right? So what I would do when the patient comes to their follow-up appointment, say, hey, listen, I think we need to have a conversation about goals of care, not about dying, just about goals of care. Can I have you come back tomorrow or next week and bring your family, bring your healthcare surrogate, and we're just going to sit down and always make it positive. It's not like, I just want to be prepared. I want to hope for the best, prepare for the worst, be covered either way, just to kind of do advanced care planning. It just normalize it. You can say, Medicare has this new code, you're entitled to it, it's part of your Medicare benefit, I want to give you all that you're entitled to. You paid for it, you might as well use it, it's free. And so Medicare wants us to do this. You can say, I have to because Medicare told me to, Medicare. Just blame it on Medicare. You blame it on bad things, you can give them good things, Medicare can do good things. Whatever you want to say, you know what the patient will respond to. And then make an appointment, and that's what the appointment is for, is to do advanced care planning. But sometimes people will never come for that appointment. So if you find that that's one of those kind of people, you just have to kind of sneak it in. So if you just say, today I'm not going to talk about their blood pressure too much. I mean, maybe a little bit, but really I'm going to focus today on advanced care planning and just kind of cut everything else short and just do it. It does sometimes take an hour, but if you know the patient and stuff, it doesn't take sometimes an hour. Or you can kind of start the conversation, give them a copy in advance. I have copies of advanced directives in my office. I have copies of most forms in my office. Print out some, take a pile on the way out, and just hand it to them and say, we'll come back next time and talk about this, So that's one thing. You just got to do it. You got to practice it because there's no exact one way. Everybody has a different technique. And then how to make this better across the whole state of Kentucky is sign up for the Most Coalition. We have calls every other month, and we meet everybody to help make this happen because people come from all over the state, and they're going to come here, and it'll be nice if they come with the most form, and we'll be done. It'd be nice to show up in your office from their primary care doctor with the most form. And all states around Kentucky have this, so. And call me. You have my website. If you have, try. If it doesn't work, call me, and we'll talk about how to make it better, yeah.
Is there a code equivalent for this? Is there a cell-phone down that should really be on
We're meeting Tuesday. We met with this NetLaw MD, and there are all kinds of companies out there that are trying. And when you build it, they will come. So Medicare built it. They built a billing code, so now you can get paid for it. So everybody wants to get paid for it. So we're meeting with this company, NetLaw MD, that has it on an app and all this. So we're trying to. It's not for free. So we're trying to get U of L, our healthcare system. U Health, is it called U Health? U of L Health. We're getting U of L Health stuff, maybe buy into it, but not yet. But we're getting there.
I have a question. If someone has most form here and they travel to Florida and they take their most form with them, since that's Kentucky's form, will they honor that? And I can envision someone who's got a life-limiting illness wanting to go to the beach.
Oh, yeah.
So how does that?
So if you know that you're going to be like, if you're a snowboarder and you go back and forth in Florida, I'd recommend you do both. One for Kentucky, one for Florida. Go ahead and have them.
I'm just going on vacation. Will the person...
So, Ed and I talked about this. Ethically, there's ethical and there's legal, right? Ethically, of course, like if someone shows up, like someone showed up in my nursing home, which has happened, from Florida with a MOST form, I was like, thank goodness they have a MOST form. I'm just going to do what this MOST form says. I still call the family, make sure. So, it depends on the doctor, right? Which, if you show up in the ER in Florida with your Kentucky MOST form, the doctors could say, I'm not going to look at this. Now, ethically, they should look at it. They should do what it says. But legally, they're freaking out, whatever. Legally, it's not legal in other states. Every state has their own MOST form, and you have to have the state that you live in to do it. But ethically, you would hope the doctor that you show up would look at it, and then they have to write their own orders. But legally, it's not 100%.
Because all the states are doing this now. So to honor the spirit of this, there's no reason not to reciprocate. We reciprocate in Indiana Post. We reciprocate Ohio MOST. And we expect those states to reciprocate for us, because these patients are going back
I'm a big fan. I think on the page, I think this is very helpful and it's great. But there's no protocol or set of rules that can cover every single situation. You never know what the future's going to bring. You speak a little bit about, doing something not following the MOST form or, exceptions to the rule. This comes up every now and then. If you have, especially, if you have the really strict rule followers in the hospital, and I've been challenged before that, a nurse shoving this form in my face, and you're not going to do this, and it can get contentious.
When it gets contentious, I'd recommend you consult palliative care, or consult the ethics committee, because you're right, it's never going to be a perfect situation. The form's not going to take care of everything. Get the healthcare surrogate involved, get the right people involved, talk to people, dialogue, document. You can always, make exceptions, but this is really a legal form that says, and that's why you make sure when you're the doctor, you have to sign this form. You want to make sure everybody understands this form. Like, hey, listen, no matter what happens, we follow this form. So if they don't agree to that, then tear up the form. Or I had this happen at the nursing home. This patient was just there for a knee rehab. She was fine. And she put on there, do not go to the hospital, no antibiotics. I'm like, listen, if this gets infected, you need antibiotics. I'm not going to sign that form, So you have to have it's a conversation. It's not the form. And you're right. It could get tricky, and just get the right people involved to help you. And try not to fight about it. It's a discussion. We can be calm people about it. Do not call the lawyers. You don't want this to end up Terry Schiavo on the news, the whole thing.
Well, I think that there's tremendous public. You're speaking to the choir. So last night, I was watching the show, and it was back to when McCain and Obama were running, and they had there was this news clip of this very, very, beat red man yelling, if you're going to try to kill, you're not going to try to kill my grandparents. It was clearly in reference to when Obama tried to put this stuff as, encouraging primary care physicians to have these very useful conversations. But the public is not on the
same page. Yeah. And Sarah Palin and the death panels and all this stuff. Yeah. Yeah.
Have these forms where people just had a knee replacement, and they signed this form at a different time, and you're not giving them antibiotics for their knee infection.
Yeah, that's why you don't sign it. Yeah, yeah.
This is what the public comes to trust, and I know you're not signing it, but
I know. Oh, yeah.
You're pulling this thing out and saying you can't give this person antibiotics.
Yeah, yeah. But I will tell you, I think our country's come a long way. Medicare is actually paying for this now. So Medicare, we've figured out that it's better to do this ahead of time, not in the crisis situation. And there's this conversation project. There's a lot of things out there about it. It's more normalized. You have a jewelry party, you have a Tupperware party, you have a goals of care discussion party, these kitchen table conversation projects and stuff. You're right. It's complicated. And so that's why to answer your question, everybody needs to be trained in this. So cardiologists, part of your fellowship, you can do everything for the heart, but when the heart fails, what do? You need to know how to have these conversations. Renal, you do everything about the kidney, but when the kidney fails, what do? No, people don't know how to have these conversations, and they screw it up. So I'd recommend that everybody rotate in palliative care or get online. There's lots of good education things. Every fellow needs to have a rotation in this because it's going to happen, and you want to do it right the first time and not cause a big red face, news program, the whole thing, because then you're trying to fix it after you did it wrong. So I agree. Yeah. Yeah.
Reciprocation between the state and the innocence who share those patients.
Not specifically. I don't know. We should. There's nothing legal about it.
And you have a form beyond that.
Mm-hmm.
A lot of limitations. You don't need a legal framework. You need a doctor to say, yes, I wanted that.
Yeah.
Yes, it's the spirit of this. We're trying to honor people's right to self-determination. If they document something in Indiana, 10 miles from here, why would I ever?
Yeah.
Because there's no state law to defend.
Don't need lawyers. Just need methods.
Yeah.
But that's a moral framework, and I certainly agree with your contention on it. But is there any legal framework to defend you?
They tried to do a legal framework, and then the House and the Senate were fighting about it. Imagine.
Well, if you ever know
The contraction forms we use the most recent.
Yeah.
it's not your own state.
Yeah. Yeah. Yeah, you should do that. But if we want to make it legal, I think that would be the next step, right? Yeah, Dr.
Numerous quote adaptations a number of years ago in Florida document when the attorney had put that we were to follow those orders, and if we were unwilling to, we would ship the patient back to Florida. Our response was to tear the form up and have the family and patients sign the new one.
For Kentucky. Oh, Indiana. You're in Indiana. That's right. Yeah, just do one for each state that you're in. That's the best thing. If you really are trying to avoid all these problems, the 100% legal, 100% best thing is do a form for Indiana and Kentucky. You can do it. We have the form. They're online. Just do it if you can do it. Yeah.
It doesn't make a Indiana form, but the family's yelling at you and wants you to do everything, but the form says do nothing.
Yeah.
You defend it in the court.
Get a good. Yeah, you just need to have a good conversation. The whole thing is we should always honor the patient's wishes. is not really the family's wishes. It's what the patient would say if they could speak for themselves. So it's complicated. We can have some conversations offline, but we have the rules and there's always exceptions. But yeah, thank you all so much. And then come up if you have other questions. And yeah, thank you.